Morning, is Dr. Rafich here from Vet Triage. It is Saturday, January 18, 2025, 9:39 a.m. Pacific Time. We are, I believe, in the last article for this October 2024 edition of Veterinary Surgery. We're going to be talking about computed tomography scan accuracy for the prediction of lobe and division of liver tumors by 4 board-certified radiologists. This study comes out of the BluePearl in Pennsylvania, Sydney School of Veterinary Medicine in Australia, the VCA in California, the VCA in Fountain Valley, California, as well as a VCA in Ontario, California, a VCA in Murrieta, California, and a VCA in Fountain Valley, California. It's the 2 Fountain Valleys. And the objective here is to evaluate the accuracy of CT scans for localization of liver masses, to assess the agreement between radiologists on localization, determine if location influences the accuracy of localization and histopathologic diagnosis, and determine what lobar vasculature radiologists found most useful for localization. Retrospective study, 67 dogs with 75 liver tumors. Let's go over some things here real quick. So the picture below is just the anatomy of a canine liver. So when we go through all these divisions and lobes, you'll know what we're talking about there. And then the difficulty here with liver masses is that we try to determine ahead of time whether or not the liver mass in a particular patient is surgical or not, meaning can we safely go in there and remove it. Now, because there's always going to be inaccuracies, whether you're talking about diagnosing it from radiographs, ultrasound, CT scan, MRI, myself as a surgeon will talk to the client about the inaccuracies involved with that and whether or not they're okay with the risk of going in surgically and deciding, whoa, this liver mass that we thought was surgical now is not surgical anymore. But it's not the end of the story there. Let's say you're dealing with a fairly stable liver mass excision, liver lobectomy, you go into surgery, and what you thought was going to be a well-circumscribed, fairly easily removable liver mass turns out not to be. You still have options there. As long as there's not a life-threatening situation where they are bleeding from this liver mass and you can't stop the bleeding unless you remove the liver mass, there are still options there. You can still get a biopsy of the liver mass. Maybe you can debulk the liver mass. The idea is to not to waste that surgery by saying, oh, I thought we could remove it, we can't, well, let's close them up. You still can get biopsies to get that client a diagnosis, because at the end of the day, that dog still will have a liver mass. And we have to find other ways to treat it. And that means radiation therapy, chemotherapy, or both. We all know that for the most part, liver masses tend to be somewhat chemo and radio resistant. However, those are still options. And until you get the biopsy, you don't know whether or not those options are viable, how viable are they, etc. So I just want to make sure that was clear. The results show an overall accuracy of mass localization was 74.3% by lobe and 88% by division. So right off the bat, you can tell that it's more accurate for the radiologist to at least say what division, right, left, or central, versus what lobe they're in. Accuracy of the quadrate lobe was 40.7%, which was lower than the caudate process of the caudate lobe at 79.2%. Left medial lobe at 73.4%, and left lateral lobe at 89.6%. Accuracy of the right lobe, which was 48.6%, was lower than for the left lateral lobe at 89.6%. Accuracy of localization was 90.1% for masses located in the left division, 77.1% in the central division, 88.3% for the right division. The agreement between radiologists was good to excellent for division and moderate to good for lobe. Conclusion: CT localization was more accurate for division than lobe. Similarly, radiologists had a better agreement for division than lobe. All right, introduction. Primary hepatobiliary tumors in dogs are uncommon and are found in 0.9% of all canine necropsies. They represent between 0.6 and 1.3 of all dog cancer. Large solitary masses are defined as massive liver tumors and are typically confined to a single lobe. Multifocal masses involving several lobes are defined as nodular tumors, and diffuse tumors are in multiple lobes and can be the result of coalescing nodular or significant effacement of the liver parenchyma. Approximately 70% of dogs diagnosed with liver mass have clinical signs. These signs include lethargy, vomiting, inappetence, anorexia, weight loss, diarrhea, PUPD, melena, seizure, ataxia. 95% of dogs will have at least one liver value elevated. Just to go back to the characterization of liver tumors, that's the three categories oncologists will use. They'll say either it's a massive liver tumor, multifocal or nodular liver tumor, or diffuse liver tumor. The canine liver can be classified as left, central, or right divisions. The left division is subdivided into left lateral and left medial lobes, and you can see it in the picture there. The central division is subdivided into quadrate lobe and right medial, and the right division consists of right lateral lobe and the caudate lobe. The caudate lobe is further subdivided into the caudate process and the papillary process. The lobes of the left division are anatomically well separated and mobile, making resection less challenging. These attachments and associated vascular anatomy make the resection of central and right tumors more difficult. A significantly higher risk of complications was found with the right divisional masses. An association between right medial liver lobe excision and a higher risk of perioperative death with a risk factor of 9.2 has been identified in previous studies. Disease within the quadrate lobe was also a negative prognostic indicator. More recently, complications during surgery were found to be less common with left divisional masses than right divisional masses, but not central. The accuracy of ultrasound is 99% for detecting liver masses. The accuracy of ultrasound for mass localization by division is between 51.8% to 74%. However, the lobe was only able to be correctly identified in 19% of cases, very low. In human medicine, CT and surgical descriptions were found to agree on the localization of 92% of liver lesions. Using the location of the liver, the hepatic lobar vein or portal vein nearest to a mass as landmarks on CT had 93% agreement with the surgical assessment of division and only 56% agreement with regard to lobation in one study. An agreement of 90.5% and 84% between divisions based on CT and operative findings has been reported in other studies. A lot of useful information there, especially if folks are in vet school who are watching this or who are in the residency. They have to take their boards. So this is all useful stuff you need to know for your boards. Materials and methods. These cases were between 2016 and 2022. Liver mass greater than 2 centimeters was a requirement, and they had to be surgically determined localization. They used a multi-detector 64-slice CT scanner. All scans were performed in sternal recumbency with 2 to 5 millimeter slice thickness, depending on body size, pre and post contrast, using non-ionic iodinated positive contrast medium at 2.2 mils per kg of omnipaque, given IV cephalic vein at a dose of 1 mil per kg for dogs with body weights less than 10 kilograms and 2 mils per kg for dogs with 10 kilogram or greater. A 30-second and 5-minute delay was used for the portal and delayed phases respectively. So when they give the contrast material IV, they then get a scan, and then they wait to get different phases. So 30-second and 5-minute waiting period. The location of the mass was recorded as left lateral, left medial, quadrate, right middle, caudate process of caudate lobe, and the papillary process of the caudate lobe. Divisions were left division, central, and right. Assessments of which lobar vasculature was most helpful, meaning portal, hepatic, or both, was also made. Results. Of dogs that were included in the study, 52.2% were spayed females, 47.8% were neutered males. Of the 75 masses included in the study, 53.3% spayed female, 46.7% neutered males. The median weight was 13.8 kilograms, where 62.7% were over 10 kilograms, meaning large breed, and less than 10 kilograms were small breed. Of the 75 masses, 64% were dogs over 10 kilograms, 36% less than 10 kilograms. Median age of 11.1 years old. And then regarding breed, 32.8% were mixed breed, 8.9% golden, 6% chihuahuas. Of the masses, 33.3% mixed breed, 9.33% golden, and 5.3% chihuahuas. Regarding the description of the masses, the mean measured size of the masses was 9.11 centimeters, and this is based on histopathology. The mean measured diameter on CT was 8.95 centimeters, so pretty close. At the time of surgery, 64% of the masses were in the left division, 16% central, 20% right division. So left division was more common. By lobation, 40.26% of masses were in the left lateral liver lobe, 24.6% located in left medial liver lobe, 3.9% quadrate, 11.69% right medial, 6.49% right lateral, 3.9% papillary process of caudate lobe, and 9.09% caudate process of the caudate lobe. So those are the most common lobation was left lateral lobe. One dog had 2 neoplasms within a single mass, and that's called a collision tumor. I've never heard of that before. Okay, regarding histopathology, 14.67% were nodular hypoplasia, 50.67% were well-differentiated hepatocellular carcinoma, 13.33% adenoma, 13.33% other cancers, 8% non-cancer. So the most common, as we all know, is well-differentiated hepatocellular carcinoma. So the other cancers include histiocytic sarcoma, fibrosarcoma, exocrine pancreatic adenocarcinoma, hemangiosarcoma, tubular adenocarcinoma, spindle cell sarcoma, poorly differentiated hepatocellular carcinoma, biliary cyst adenoma, liposarcoma, moderately differentiated hepatocellular carcinoma. You want to know that for your surgery boards. Non-neoplastic include abscess, suppurative hepatitis, sinus telangiectasia, hepatic cyst, and diffuse hepatocellular vascular change, or vacuolar change. All right, statistical analysis. Radiologists made 292 localizations by lobe. Of these, 74.3% were correct. Accuracy of quadrate lobe was lower than caudate process of caudate lobe, left medial lobe, and left lateral lobe. Accuracy of right lateral lobe was lower than that of left lateral lobe. Overall, radiologists made 300 localizations by division, 88% accuracy. All 4 radiologists agreed on the lobation in 56% of cases. All pairs of radiologist comparisons had at least moderate agreement with good agreement between some of them. All 4 radiologists had 81% agreement on division of masses. All radiologist pairs had strong correlation in size measurements, and correlations were highly significant. The radiologist made 295 assessments of what circulation, hepatic vasculature, was most useful. 34.9% thought portal venous phase was most important, 26.8% hepatic venous, 38.3% for both. No association between weight and histological diagnosis or age and diagnosis was found. No association between liver lobe division and whether complete margins were obtained between liver lobe, and whether complete margins were obtained between histologic diagnosis and whether complete margins. So there's no correlation between all those things. That's pretty crazy. Okay, discussion, and let's show you some CT scans. There you go. You can see the CT scans. There's the, if you want to pause the video, you can look at the description there. And then we have some more descriptions here, images, CT scan. Discussion. CT localization was more accurate for division at 88% than for lobe at 74.3%. Radiologists tended to agree more for division with good to excellent correlation than lobe, which is moderate to good correlation. All radiologist comparisons had strong correlation for size measurements. No significant association between weight or age and diagnosis was found. No association between diagnosis, liver division, or lobe, or whether complete margins were obtained. 34.9% of responses, the portal venous phase was the most useful, 26.8% hepatic, and 38.3% thought both were equally useful. The nearly equal distribution of gender in the study is similar to the 57% male and 43% female reported previously. The dogs here had a mean weight of 13.8 kilograms, which is less than a prior study of 20.6 kilograms. The mean age of 10.9 years, and the tumor-specific age previously reported with liver masses is consistent as well. These findings are consistent with a lack of breed predilection, as previously reported. Mean measured size of the masses in this study was 11.3 centimeters, similar to prior studies. Distribution of masses by division in the current study is similar to the 53 to 58% left division, 12 to 27% in the central, and 14 to 35% of the right division. So left division is most common. With lobation distribution, they're also similar, as previous studies showed: 33 to 40% left lateral, 21 to 25% left medial, 11 to 16% quadrate, 15 to 19% right medial, 7% right lateral, 6 to 8% caudate, both processes, making left lateral of the left division the most common. Hepatocellular carcinoma was the most common tumor type in our study, which is similar to other reports. Overall accuracy of liver division localization in this study was 88%, similar to 84 to 93% reported previously. The trend in accuracy of localization was highest for left division at 90.1%, compared with masses located in the central division, 77.1%, right division, 88.3%. These results are similar for the right and left divisions, but not central, compared to another study who reported a positive predictive value of 88% for left division, 43% central, 75% right. These divisional differences might be true on ultrasound as well. It would seem logical for the left division to have the highest accuracy, as it has the largest volume of the lobes. And you can see there on the picture that it's got the highest quantity of lobes in it, left division. In contrast, only 60% of masses in the right of midline were right divisional. In the present study, there's a lower accuracy for identifying masses location by lobe compared to division. In addition to the lower overall accuracy, the accuracy of the quadrate lobe was significantly lower than for the quadrate process of the caudate lobe and the left medial lobe and left lateral lobe. Accuracy of the right lateral lobe was significantly lower than left lateral. Although in the present study found a much higher accuracy, 74.3%, than reported previously at 56%, there is still a likelihood, 25.7%, that a tumor could be incorrectly localized. The lower accuracy by lobe versus division might be related to the small size of the individual lobes, less distinct anatomical markers for lobes, individual vascular variants, or distortion of the anatomy by masses. Positive contrast CT peritoneography could aid in more accurate localization. When comparing the individual accuracy of radiologists by lobe, there are significant differences in individual accuracies ranging from 54.8% to 83.1%. The agreement between radiologists was good to excellent for division, but only moderate to good for lobation. This supports that lobe localization may not be reliably evaluated on CT, but division can be. The most experienced radiologist in the study was also the most accurate for lobation and division. In human medicine, manual segmentation of the liver by radiologists is time-consuming and prone to error. The use of artificial intelligence in the form of convolutional neural networks has demonstrated significant promise for automated segmentation of the human liver. These same principles of machine learning have already been applied in the veterinary space to evaluate CT imaging characteristics of hepatic masses as predictors of malignancy. It has been previously reported that CT features, including the post-contrast enhancement pattern of these lesions and legionel's maximal transverse diameter, have a high accuracy for predicting malignancy. And that usually makes sense because malignant tumors are usually more vascular because they're growing fast and prone to spread. So if they have more vasculature, it means that they're going to pick up more contrast material when administered to the patient. All right, pretty good study. Obviously, my criticisms are going to be, as always, we need more cases to get better accuracies, but also it'd be cool to know like post-op complications, because if we're going to say that a certain division of liver lobe has a higher risk of complications, either in surgery or post-op, it'd be nice to have that here. Obviously, it's a multi-institutional study, which has its limitations, and follow-up and consistency rather with everything in medical records is a major issue with that. So, all right, thanks for those who support the channel. We'll see you again tomorrow. Bye.